So, hello everybody again. I've got only a couple of cases today. The first case is gastrectomy in a very young adult female patient, and she was diagnosed with germline mutation in cadherin-1 gene. So she's at the risk of having lobular carcinoma of the breast and, most importantly, gastric diffuse cancer. So she underwent prophylactic gastrectomy, and what I have done, I have submitted the whole stomach into blocks, and I have sat down for several hours to look at all the slides. And because macroscopically there was nothing, but already here microscopically you can see very early diffuse cyanide ring carcinoma, or according to the WHO classification, poorly cohesive carcinoma. Okay, so I had more than 120 slides. No. I found the gastric cancer in eight slides, eight blocks, and there were 10 separate foci of very early carcinoma.
Where did they do the genetic?
I don't know.
Where was all the genetics?
I don't know. Moreover, the patient is diagnosed with BRCA mutation, so she is at risk for some other lesions. Okay, so I had to be very, very careful with reviewing all the slides. This is the biggest focus of the cancer I have found. So, and already you see it occupies almost one half of the lamina propria, and in contrast to cancers in let's say in colon, even intramucosal cancers in the stomach may metastasize because they have already access to small lymphatic channels. And fortunately for this patient, the resection margins are clear of the cancer, and all examined lymph nodes, 10 or 11, were negative for malignancy. And I really tried very hard to find something what is called cyanide ring cell carcinoma in situ, and I'm not really very sure with that, but probably something like that is here. Okay, you see these mucinous glands in the area of below the. Okay, so the cells are really blunt looking, but the cytology is very much like the invasive component. So I found two or three foci like this. Okay, so maybe we should be more careful with lesions.
Can you imagine if you would the grossing neglect, laying only a few blocks and
yeah.
The patient would
you will miss the cancer very easily, and patient will live. I have nothing. I'm safe, but she's not safe. Okay.
She would probably see this.
Yeah. So the message, the moral of the story in this case is always submit the whole stomach, and this is really in the guidelines. If you have resources for doing that, we have. Okay, it's just labor intensive, but we can do that. We should always submit all the tissue and examine under the microscope. Okay. So another case. This is a 2-year-old child, and the kid had some skin tag on the smallest finger on her hand. And what can you see here is intact epidermis, and this proliferation of this haphazard proliferation of small nerves. It looks a little bit like traumatic neuroma or amputation neuroma, but it's a small child, and he's got this lesion on ulnar side of small finger. So this is, I believe, rudimentary digit. Okay. Okay, so this is just curiosity, rare thing, and not to be diagnosed as amputation neuroma. Okay, because the child has no history of operation and.
You will have amputation neuroma in a few years.
Yeah. After this surgery. Okay. So my another case is older lady, and this is endometrial polyp, and this is just to remind you that when examining these polyps, we always have to be really careful not to miss important lesions there. And I always examine the whole surface of the polyp, because you may find this. Okay, so this is glandular looking, a little bit reminiscent of endometrioid lesion, but in fact it's not. Okay. Yeah, sure. It's
P53?
yes, it's diffusely P53 positive. Okay, here and here and here.
You should know that even if it is inside the lesion, it can metastasize even being inside,
Yeah,
because
exactly.
it discharged to bring access into the abdomen cavity and it can invade the abdomen cavity.
So this is P16 staining. So it's serous intraepithelial carcinoma, or previously called in situ serous carcinoma. And as Michal said, this lesion already may give rise to distant peritoneal metastatic disease. Okay, so we.
This P16 is normal, meaning because it definitely is not driven, I'm sure.
Yeah. My last case for today is biopsy from mass from the pancreas, from the tail of the pancreas. Okay, you can see pancreatic tissue here, and this little bit lymphoid-like tissue here. So the question was, is it neuroendocrine tumor? Because on ultrasound it was roundish lump next to the tail of the pancreas. So any suggestions from here? So one immunostain. Okay, I will give you. This is CD8 staining, and in addition to staining small T lymphocytes, you see this CD8 positivity in these vascular channels. So it's spleen. It's accessory spleen next to the tail of the pancreas. Okay. And it's negative for cytokeratin, so it's not epithelial tumor. So that's it.
Please stay there, and I will show quickly in absence of our breast specialist, Zdeněk is absent. So this is a 80-year-old lady with a resistance in her breast, and it's a very small, tiny cord biopsy, and if you open it a little bit more, you can see that it's not benign, and it's most likely not carcinoma. And if you want me to show egg, or CD31 or CD34, it's positive. Please, there. So diagnosis is angiosarcoma of the breast, which is very rare. Lesion. I will not be so self-confident to present here just small parts of it, but it's very current. This lady had already been diagnosed for angiosarcoma, and this is recurrent tumor.
So this is ERK protein staining.
Yeah. So angiosarcoma of the breast in old lady in forehead biopsy.
So was she irradiated because of something else, or?
Probably yes, because this is as always, it's not given. The medical history, full medical history is not given, but at least they were kind enough to say that there is angiosarcoma in their medical history. So thank you, and now I have something which you will not be definitely interested in, but it's beautiful. And these are two cases of salivary glands. And the first one is here, and it's a shared material because I was looking for it. Of course, it's a parotid gland, and then we have this well circumscribed region composed of small tubular structures, very tightly packed together. And if you even open excellent, and now you can see that these tubular structures are monophasic, not biphasic. One would expect that it's a biphasic lesion. It's completely benign, and the name is triapic duct adenoma. There are two possibilities of these super rare lesions. Intercalated duct adenoma is biphasic, striated duct adenoma is monophasic. And these tumors, we are collecting them. It came from England because we would like to write about it. It's IDH. Yes, IDH2. Yes, it's not done so far. But the next one, it's pretty much very different, but diagnosis is the same. Again, parotid gland with well circumscribed lesion, which is somewhere, and this other possibility. The ducts may be quite cystically dilated. They may even look like, that's even written in the blue book, that they may resemble thyroid gland follicles, this colloid, and again, it's on high magnification, monophasic, monolayered lesion, pretty benign, and both of these are striated duct adenomas, and we have one in the registry, so it's very rare. And I was looking for such cases. So if you see something like that, not everything is a well-known adenoma. So give me such cases.
Okay.
So I have a couple of gynecological cases. The first one is clinically endometrial polyp, and girl is 21 years old, and this is probably the clinical polyp, so highly myxoid lesion. And the tumor cells are spindled with some atypia, but not so striking atypia. There was no mitotic activity, no atypical mitosis. So there is the differential diagnosis includes myxoid tumors of the uterus. On the first place, I think this is suggestive. Also, I didn't show the presence of inflammatory infiltration, so the first place here would be inflammatory myofibroblastic tumor, but then we have to take into consideration other uterine tumors with myxoid features, including myxoid leiomyosarcoma or B-core rearranged stromosarcomas. And this is ALK immunohistochemistry, which was diffusely positive in the nuclei of tumor cells. So the diagnosis here was straightforward. Other markers were negative. This is ALK. ALK. I said that. I'm sorry if I said that. So not loud. So this is inflammatory myofibroblastic tumor, which is a tumor of borderline malignancy, and they quite often recur, and rarely they can also metastasize. But regarding the tumors which are limited to uterus, as it was probably this case because it was a uterine polyp, there are quite limited data. So the aggressive features are regarded a large tumor size, more than 5 or 7 centimeters, infiltrative growth, presence of tumor necrosis, presence of atypical mitosis. Nothing was seen in this tumor, but for sure infiltrative growth was probably present, but it's hard to say because we have just fragments of tissue. And we will be confirming, or rather doing the genetics to find out the fusion partner with the ALK.
Was it done already? Was it done?
No, it's a fresh case. It's diagnosed today.
Did you try that? Did you do the genetics?
Yes, it's already ordered. And this is another case, woman aged 70 years old, woman, and she had intramural tumor in uterus and clinically suspicious of leiomyoma. So from the morphology, it is a clearly malignant tumor. There were many of tumor necrosis. The tumor grew infiltratively. It is atypical. So if myomatous tumor, it would be leiomyosarcoma, but in this case epithelioid. But also this is not straightforward from this morphology. So you'll have to order immuno in this case and not one. In some areas, there were areas with somewhat tubular architecture. So in these areas, it resembled so-called utrosk, so uterine tumor resembling sex cord stromal tumors. So this was a tumor included in a differential diagnosis as well. And as for immunohistochemistry, this case was diffusely positive for actin, which is non-specific, but it was positive. It was positive for CD10, also diffusely. It was negative with, or partially positive with H. caldesmon. I don't know where it is here. So H. caldesmon was positive like this, so some foci of quite strong positivity, but not all over the tumor. Then, because of this utrosk-like morphology in some areas, this is SF1, but it was completely negative, as well as other sex cord markers. And because of the recently published series of tumors published by Michal, who just left, plaque-1 rearranged tumors, this is plaque, and it was faintly positive, but this wasn't very very convincing. So we did genetics for sure, 2 rounds of NGS, and there was no fusion nor mutation present. But then we ordered PLAC1 fish, which was positive. So this is PLAC1 rearranged tumor sarcoma, and but we failed to detect, or geneticists failed to detect the fusion partner, and Michael told me they had 1 case of tumor of PLAC1 rearranged sarcoma without fusion partner, so it's possible to have that, albeit quite rare, probably.
There probably is a fusion partner, but the sequencing assays we have are not able to detect it sometimes.
Yes, thank you. And I was about to say something else. Yeah, according to the cohort published by Michal, these tumors are probably aggressive tumors, because I think you have 4, almost all tumors with available follow-up behave aggressively. They recur, and some of them are also metastasized, right? They have distant metastasis.
Are you focused on the small, so the scanning modification? This is fine, but the scanning modification is not focused on the screen.
Je to dobré vidno. Treba radšej väčšie zväčšenie.
Jo.
Ale nie rýchlo to skanovať.
Už ukaž si to, že si čujem.
Radšej pomaly.
Dobře. So this was PLAC1 rearranged sarcoma. So new case. Another case was sent for consult with suspicion of mucinous. It's ovary, and the girl is 20 years old, and they had suspicion for mucinous carcinoma arising in the setting of teratoma. So here we have classic teratoma. There is nothing interesting in here. So this is a section with classic teratoma, and here in other areas there was a part where the mucinous tumor was present. Here we have part of mucinous tumor. It was mostly lined by blunt mucinous epithelium, but in some areas there were sections where the tumor was lined by more atypical epithelium, as here. And there were also areas where there was intersection of the extracellular mucin into the ovary. So the overall appearance was pseudomyxoma ovarii. And once we have cases of mucinous tumors in ovary, we have in general 3 main differential diagnostic possibilities. The first one is a mucinous tumor arising in the setting of teratoma, which was this case, and this case was easy because we had teratoma, but sometimes we couldn't find teratoma, so we have to exclude 2 other main possibilities, which is metastasis to the ovary from usually mucinous tumors of upper gastrointestinal tract, And the third option are primary epithelial mucinous tumors of the ovary. So this case, in this case, it was about assessing the biological behavior of the mucinous component, but otherwise we could for certain say that it was of germ cell origin. And I think this was not carcinoma, but rather borderline tumor of mucinous epithelium.
CDX1?
I didn't do that, but yeah, there is a possibility this could be mucinous tumor metastasizing, and I also, yeah, you are right that another option is that there is a mucinous tumor metastasizing into the teratoma, but as this girl, I suggested this possibility in the on conclusion of the biopsy, but the girl was 20 years old, so I also told them that it is not very probable, but they have to, before they assess this tumor as a primer, they have to exclude the possibility of metastasis. I know it's possible, but yeah, not very much. So
I believe that even this mucinous lesion in teratoma will be CDX2.
yeah, they usually have overlapping immunophenotype.
The only useful immunohistochemistry is FAST8. About one of these cases will be FAST8 positive, and then you are sure it's from the teratoma or primary ovarian origin.
Yeah, but some of them are even PAX negative, and they still arise from teratoma. So this is not very reliable. I think the best clue is to exclude it by clinic examination. Yeah, but they have overlapping immunophenotype, so it's not very helpful. Another biopsy is a girl, 2007 born, so young woman, and they took out both gonads. This is one of it. And she has a girlish name, and she was regarded as a girl, but regarding her karyotype, which is 46XY, she's not a girl. She's a boy with androgen insensitivity syndrome, which means that she was born as a boy having a Y chromosome, but there is no sensitivity of peripheral tissues to androgens. So it means that there are no ovaries. Instead, there is something looking like testes, but not normal testes. There are usually there are almost no germ cells. Sorry. These are Sertoli cell only tubules, which are presented instead of the gonads. And sometimes these Sertoli cell only tubules form tumor lesions, which are called Sertoli cell adenomas or pig adenomas. This is something which can be maybe regarded as this lesion, as it is well circumscribed from the surroundings. So there are it is entirely benign lesion, composed of just Sertoli cells. This is a tumor not similar to Sertoli cell tumor NOS. It is probably of non-neoplastic origin, just rather of hamartomatous origin.
I saw cases that were 3 kilograms of weight, can be non-neoplastic. Yeah.
Okay, but
it's very often big one, huge one. Yeah. It's historically it's called hamartoma, but most hamartomas are neoplastic.
Maybe, and except that there are usually also present Leydig cells, which were not present in this case, but they form also hamartomatous lesion composed of irregular mixture of Sertoli cells and Leydig cells together, and these patients, as they look like women, and they only go to surgery or they go to search medical treatment because they do not have ovulation, they do not menstruate, but otherwise they live like women and they are according to the data satisfied as being women.
Probably that Algerian boxer lady. Because she had a female external organs, but she never wanted to bring a chromosome and very often she said, this boxer.
And she almost killed the competition.
It is said that Greta Garbo, this was man as well, Greta Garbo, and she had this syndrome as well.
And these patients has external genitalia as women because there is an absence of androgen stimulation with the effect of virilization of the urogenital sinus. So they have external female type of genitalia, but because there are present Sertoli cells which normally secretes anti-Müllerian hormone, there are no fallopian tubes, no other derivatives of Müllerian structures as upper part of vagina, uterus, and fallopian tubes. And
it can be traced to some animal.
Quite rarely, but yeah.
Genders, I would like to ask them what the gender is this. It looks like men, genetically it's male,
But
beautiful men, yeah.
according to themselves, they feel like women, and they are females, and they're okay with that.
So as females because they identify themselves.
It's okay until they go to box Olympic Games.
And my last case is also a young girl, 2008, and this is her ovary. And she has also this is in-house case from today, so I don't have any immuno available, but it is a beautiful lesion, and she has also gonadal dysgenesis, and this is a mixed sex cord stromal and germ cell tumor arising in the setting of dysgenetic gonads. And it has, once you see it, you will recognize it every time after you see that, because it's very typical appearance. There is a mixture of germ cells and sex cord cells together with this material of basal membranes and frequently calcification. Yes, it's gonadoblastoma. The diagnosis is gonadoblastoma. So typically the germ cells are these large cells with abundant pale cytoplasm, and sex cord cells are the remaining cells. There are probably more sex cord cells than germ cells. The sex cord cells have more scarce cytoplasm, and they are mixtured together with these voluminous germ cells. And some of the sex cord cells resemble Leydig cells. They are called Leydig-like cells, but they are not classic Leydig cells or not prototypical Leydig cells. So this is a typical example of gonadoblastoma arising in dysgenetic gonads.
You're a lucky pathologist.
Sorry?
You're a lucky pathologist.
Yeah, this case and also the androgen insensitivity syndrome came within 1 week. And these are just routine cases from Chicago. So yeah, I was excited today. And this is my last case and my last work.
This case is very important to distinguish from Gallagher tumor. Gallagher tumor typically does not have the genetic gonads, so it starts in gonads. It looks different.
And it's also morphologically a little bit different. It does not have the Leydig-like cells and the calcifications, also the material basal membranes.
Okay, hello everyone. My next case is an old lady with a widely metastatic tumor, which affected her bones, several bones, and also mediastinum, both lungs as well. So really widespread aggressive tumor. It's a 5 or 6 years old case. I was looking for the slide for another reason, because we have this patient in a study, but I wanted to know what this lesion was actually. So I got these slides. This case was diagnosed as undifferentiated pleomorphic sarcoma at that time, because it really is undifferentiated, ugly-looking tumor, which was basically immunohistochemically negative for everything. Everything was negative here. But when you look at the morphology and you kind of think about the very aggressive clinical course and think about the frequency of various malignancies, there is definitely a top differential diagnosis, which is undifferentiated melanoma. You see these large round to rhabdoid cells with prominent nucleoli, a lot of mitotic activity, huge areas of necrosis. So by just seeing this, you should think about undifferentiated melanoma in a patient with a widespread disease. And indeed, when I looked in the documents of the patient, she had a melanoma signed out 8 years prior to this biopsy. So even though S100, SOX10, all the melanoma markers are negative, with this history in the patient, you can with very high likelihood say this is undifferentiated metastatic melanoma. No, it's an old case and we don't need it, so I didn't do. But methylation profiling is definitely a way how to diagnose these tumors, which are negative for immuno and negative for the classic melanoma mutations. You can still do methylation, and very often you will get some conclusive result. Actually, this is one of such examples. Next case. It's an axillary lesion in a 74-year-old male. Axilla is a typical first location for metastatic melanoma if it occurs on the upper extremities or close to axilla somewhere. Again, you see highly undifferentiated tumor composed of these epithelioid to sometimes rhabdoid cells, huge mitotic activity, a lot of atypical mitoses, prominent nucleoli, and again, every immuno is negative. Sometimes you see quite prominent pleomorphism. Very typical of undifferentiated melanoma morphologically is that you see various growth patterns. You can see spindle cell areas at one side of the tumor and undifferentiated round or epithelioid cell areas in the other half, or pleomorphic areas somewhere in the middle. So this mixture of various growth patterns is sometimes helpful. Don't get discouraged from the diagnosis by positive cytokeratins or positive rhabdomyosarcoma markers. Desmin, MyoD1 is often positive. You can call it then so-called trans-differentiated melanoma. These are cytokeratins here. You can see quite prominent cytokeratin positivity. But still, this patient had a history of melanoma. Also, the tumor had an NRAS mutation, and by methylation, there was a 73% likelihood or match with like a control group of confirmed melanomas. So although the match is not perfect, a perfect match is over 90%. Still, in association with the other findings, it's highly suggestive, or almost 100% certain it's a melanoma metastasis.
This patient very nicely responds to BRAF inhibitors.
Not only to BRAF inhibitors, well, if they have BRAF mutation, they respond to BRAF inhibitors, but most importantly, almost all of these undifferentiated melanomas, whether they have BRAF or NRAS, they respond to immunotherapy. So this actually, I would say in soft tissue pathology, the most important tumor not to miss is undifferentiated melanoma, because it's one of the most common high-grade malignancies we see in soft tissue. And if you call it undifferentiated pleomorphic sarcoma and you don't take action to diagnose melanoma, you will basically not allow the patient to be treated with these modern drugs. Okay, another case, one more example. This is a widespread peritoneal disease in a 52-year-old female. She did not have a history, or at least we didn't know about the history of melanoma. Again, when you look at it closely, you see these round to epithelioid cells. Again, these prominent nucleoli, I mean, they are not specific for melanoma, but they should be there most of the time. High mitotic activity and everything. Here we did methylation analysis, and there was a 99% match with melanoma. So again, in correlation with the morphology and the widespread disease, this is highly suggestive of melanoma, undifferentiated melanoma. Okay, I will just show you one. There was methylation profiling was done. There was 99% concordance with melanoma. I will show you just one paper, which I think every pathologist should do, no matter what specialization they have. Just give us a little bit time. I think it's showing the other screen here. Okay, we have some technical issues here, but it's an old paper, it's 4-year-old paper by Abbas Agaimi. He published 2 papers on this topic. We will try to send this publication to everybody listening here. And I strongly recommend every pathologist to read this, no matter if you're a resident or a seasoned pathologist. This is a highly important issue, especially because of the therapeutic choices for these tumors. And really, it has been called a great mimicker since many decades, but these papers that came out in recent years confirm it's even better mimicker than we have thought before. Okay, this is another case, another topic. It's a finger lesion in a 70-year-old male. So I'll try to go slowly around the slide. You can notice a very prominent inflammatory infiltrate. It's so prominent that sometimes this is considered for some hematological lesion or hematological malignancy, which is quite understandable given the dense lymphoid infiltrate. But it's just one of the clues for the tumor, because the diagnostic areas are outside of the inflammatory infiltrate in these myxoid areas. Again, it's a finger of an elderly patient, which is a typical location for these tumors. I'm sure some people in this room already know, or surely somebody online knows as well. Yes, you can see here in the middle, so-called RS-like cells. I'm trying to bring the arrow in. You can see here RS-like cells, basically 2 nuclei next to each other, but it's not Rossi-Dorfman disease. It just the cells resemble it a little bit. Then I'll show another slide from this patient where we have other good areas. Again, highly infiltrative, inflammatory lesion, but don't dismiss these myxoid areas for nothing. It's the clue for the diagnosis, and these areas are actually the best. Again, cells with prominent so-called virocyte-like nucleoli, at least some of them. You can see here, maybe. Yeah, then in these myxoid areas, the mucin gets inside of some of the cells, which are then vacuolated like this. They are sometimes resembled to soccer balls or lipoblasts. And sometimes you can see emperipolysis, which is like a ingestion, or basically the tumor cells eat the surrounding inflammatory cells, and the inflammatory cells are in the cytoplasm. So this combination of features, the inflammatory infiltrate, these RS-like cells with prominent nucleoli, these myxoid areas with mucin inside of the cells, together form a picture of so-called myxo-inflammatory fibroblastic sarcoma, tumor described 26 years ago by 3 different groups. One of them was my father.
It was routine biopsies?
No, it was consultation. It's not from recent time. So another case here, it was a young adult, tumor somewhere in soft tissues, highly cellular blue tumor. And when I go on higher power, perhaps the most striking feature of this tumor, besides that it's cellular and blue, is that the cells are very much like each other and they don't overlap too much. So it's a round cell tumor. Of course, you have to exclude melanomas, carcinomas. Perhaps also it's not a bad idea to do some lymphoid markers, although it doesn't look very good for lymphomas. And then, youngish person, you should think of round cell sarcomas. And when you, by exclusion of the others, arrive at the possibility this could be a round cell sarcoma, it's very important to take into consideration the perfect uniformity of these tumors, because that's a hallmark of Ewing sarcomas. So although you should, or most people want to have this diagnosis confirmed by genetics, there are pretty good immunohistochemical markers which can highly increase the pre-test likelihood before molecular testing, which will give you a higher chance of getting Ewing sarcoma right. This is CD99, old stain, but still works pretty well. It's very non-specific, but when you see this diffuse, strong membranous expression, the specificity highly increases. Still not perfectly specific, but helps. It's very unlikely to see Ewing sarcoma without this diffuse membranous positivity. It exists, but it's very rare. And the other good marker is NKX2.2, also not perfectly specific, but when you see diffuse nuclear staining, such as here, again, you highly increase the probability this will be Ewing sarcoma. And when you have this morphology, clinical, and immunohistochemical constellation, I would suggest not to order NGS. I would just go for FISH if you have it available. FISH not only for EWSR1 but also for FLY1 and ERK, because it will be much faster. You will have results in 3 days if your lab works well. Okay, next case. It's a middle-aged woman in her 50s, small tumor on her fingers. So far we have talked about generally quite serious sarcoma diagnosis. This one is kind of cute, little innocent lesion, typically on the fingers of a middle-aged female. You can see here the skin, overlying skin, and in the dermis and maybe superficial areas of subcutis, you see this proliferation of epithelioid cells, which are, however, pretty much bland. There is no much mitotic activity. And what is highly suggestive of the diagnosis are these beautiful psammomatoid calcifications. It's not papillary thyroid carcinoma metastasis. If you stain these cells for histiocytic markers, you will get confirmed these are all histiocytes. It's actually a non-neoplastic lesion, which is called tenosynovitis with pseudomatous calcifications. It was described some 20 years ago by Andrew Fulp, and a couple of years after that, in 2019, we collected the biggest collection of these tumors, and basically everything what is important is in the name of the paper and in the subtitle. So it's a subtype of idiopathic calcifying tenosynovitis. There is a strong predilection for fingers, especially on the hands, but also on the toes, and typically in middle-aged women. And it's most likely a result of kind of chronic, repetitive, small injuries to the fingers. So tenosynovitis with pseudomatous calcification. It's a orthopedic pathology, but basically, since it's on the fingers, you can see it wherever you practice. And last topic, this was a 35-year-old male with a on X-ray well-defined lesion in his acetabulum, in the femoral head. It was a lytic lesion. It was huge, 12.5 centimeters. But was a kind of like expansive growing. Wasn't infiltrative. And this is the morphology. Basically, the bony trabeculae were infiltrated by this relatively uniform epithelioid cells with clear cytoplasm. There wasn't very prominent mitotic activity. You can appreciate that there's like a woven bone production by the tumor cells. In some other areas, you can sometimes see cartilage production as well. And this is a kind of like a textbook example of somebody has an idea. Exactly, clear cell chondrosarcoma. So in this case, not all tumors that are called clear cell are composed of clear cells, like clear cell sarcoma, for example. It's not typically composed of clear cells, but here it kind of fits. It's mostly clear cell cytoplasm. Pretty uniform cells in most cases. The tumor is, when it's detected in time, it's quite indolent. It's a low grade sarcoma. If it's detected early and completely resected, usually that doesn't recur or metastasize. But when it's detected too late, such as in this case, it can of course have distant metastasis. It's a sarcoma. So clear cell chondrosarcoma.
The rarest chondrosarcoma subtype.
Yeah. It's a special subtype of chondrosarcoma. It's genetically completely different from the conventional chondrosarcoma. This is important to mention, and it's very rare. This is another example of the same tumor. It's an old slide, so there are bubbles, but still you can see areas with pretty much the same morphology as we saw before. Another clue, besides the clear cell cytoplasm, is this very prominent cytoplasmic membrane, which you can see in most cells. So clear cell chondrosarcoma, and that's my last case to show you. And I think we are pretty much done.
I think so.
Okay, so
Next time.
whoever was listening, thank you for your attention, and talk to you next time.